Welcome everyone to today's call. I appreciate you all coming out. And as the title indicates, today I want to discuss optimizing neurologic rehabilitation. And you might say, why does this apply in a functional medicine model? And the answer is because everything applies in a functional medicine model, silly. Because functional medicine looks at the entire person. And so if we're talking about neurologic disorders, whether we're talking about mild traumatic brain injury from, say, a concussion, or we're talking about a neurodegenerative issue such as Parkinson's disease or Alzheimer's disease, or a neuroautoimmune issue like PANDAS or multiple sclerosis. The information on today's call is going to be key in realizing the optimization of not only neurologic function, but physiology as a whole for the individual suffering from those conditions or others that I haven't listed. And the reason that this call is important is that in conventional medicine, as I'm sure many of you on the call have experienced, focuses on the complaints, right? Conventional medicine, mainstream medicine is very specialist focused. If you have a head injury or a neurologic symptom, you have to get a referral to a neurologist, and they are king of your neurologic complaints. They're the ones that are the go-to specialists. They get to dictate care. The problem with that is that the nervous system is impacted by your global physiology. And it's been my experience in working with people with neurologic disorders from pediatric all the way to geriatric that they'll see a neurologist who, of course, is focused on the neurologic symptoms, but if they report symptoms outside or that seem to be outside of the nervous system, the neurologist kind of can give them a look and be like, that's, why are you telling me that, right? So an example would be a patient with a concussion often has a GI issue following the concussion. And the reason for that is the research shows that in concussion, often within 6 hours, you can develop a leaky gut. And the more concussions you have, the higher the probability that that occurs with each successive concussion. And so if you're having GI issues, the neurologist should be interested in that if they're up to date on the research, because you might be able to pass the concussion test, like following the pen with your eyes, remembering 3 words 10 minutes later, different things like that. But you could pass that test and then go chemically reconcuss if you eat gluten or you eat dairy or you eat something you're sensitive to as a result of the leaky gut that developed post head injury or from the head injury. So the neurologist should be very interested in your gut. Another reason, if you've read my book called The Autoimmune Answer, is that in chapter 3, I talk about how the gut has its own nervous system called the enteric nervous system. So the brain and spinal cord are the central nervous system, while the gut is under the control of the central nervous system and the enteric nervous system. So in my mind, a neurologist should care more about the gut than the brain because the gut has 2 nervous systems. But anyway, that's a little soapbox moment. So we want to discuss optimizing neurologic rehab by zooming out and looking at the whole person versus just being myopic and a specialist that only considers the brain. And the reason for that will be clear as we go. And like I said, if you suffer or know someone or care for someone who suffers from pediatric neuroautoimmunity like PANDAS or multiple sclerosis in middle age, or Parkinson's disease or Alzheimer's in geriatric stage, this presentation is useful to you and to that person. So I want to use Parkinson's disease as a case example because Parkinson's disease is the #2 most common neurodegenerative disease in the US. #1 is Alzheimer's disease. And like I said, what we talk about today is going to apply to Parkinson's, Alzheimer's, PANDAS, MS, whatever we're talking about neurologically. So in Parkinson's disease, the issue is in the basal ganglia. So if you look at this slice through the brain here, these 3 blue dots in the middle constitute the basal ganglia. And the basal ganglia is the part of the brain that drives motor function, either the gas pedal so you can go, 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 or the brake pedal so you slow down and stop. And in Parkinson's disease, you have attack on dopaminergic neurons, so you have less dopamine, so you have less gas pedal. Therefore, the brake pedal wins and you get these slowing down, right? If you know anyone with Parkinson's, they walk really slow. They shuffle with their gait. Their arms are drawn up in. They might have a pill rolling tremor. They have a masked face. If it's pretty progressed, they can't really close their mouth. They drool. All of these things. So Parkinson's disease is a slowing down of motor function, and that's due to dopamine. So conventional medicine, the gold standard treatment is levodopa carbidopa, right? So levodopa helps promote dopamine efficiency, but it also increases homocysteine, and homocysteine speeds neurodegeneration. So what you see with Parkinson's patients is they go on levodopa, they may get a boost from the improved dopamine efficiency, but over time they need to continue to increase their dose. And the reason that they have to do that is because one reason could be that the homocysteine is being increased due to the medication, which increases neurodegeneration and death of neurons, speeding the disease process. So what do we do beyond just providing dopamine efficiency, right? One thing you could do is rehabilitate the brain. So with functional neurology, you can drive efficiency in the pathways that feed into the basal ganglia and feed into better movement, better motor patterning, better speech, etc. And so we want to do that with Parkinson's patients. And you'll see even in conventional medicine today, they recommend that Parkinson's patients stay active, exercise. There's a gym called Rockbox, and that gym has classes for Parkinson's patients that they can go and box and be active, because high intensity interval training has been shown to slow progress of Parkinson's disease. Leg strength has been shown to slow progress of Parkinson's disease. So promoting leg exercises from sit to stand squatting in a chair all the way up to, weighted squats at the gym, depending on the person's capacity for that. So again, conventional medicine is going to hear Parkinson's, okay, levodopa, this is what we do. Let's zoom into that part of the disease process and focus on that. And they do that, but that's only one piece. There's a whole rest of a person that could be addressed, and that, could improve what levodopa is doing, or if you improve the rest of the physiologic processes that may be gone awry or have a stick in the spoke, so to speak, maybe they don't need levodopa. So here's an example. We've all maybe seen this person. Parkinson's disease slows us down in movement. It slows us down in thought. It slows us down in speech. So it's not just, grandpa walks so slow to the car. It's grandpa's thought processes are slow. Grandpa being able to communicate with us is slow. Grandpa's bowels are slow. Everything's slow. And so if we want to rehabilitate a neurodegenerative disease optimally, if we want to rehabilitate someone who's suffering from a concussion optimally, if we want to rehabilitate a child with PANDAS optimally, we need to zoom out away from the brain only and look at the rest of the system. And this graphic does a great job of helping us understand that. This graphic is copyright of functional neurology seminars, Drs. Datis Karazian and Brandon Brock, and I thank them for their education and providing this awesome graphic, because I've shown it to many patients over the years. And it might look kind of crazy, but it's pretty easy to understand once I explain it to you. So a healthy neuron, a neuron is a brain cell, okay? So a neuron, one neuron has to has to create a action potential to communicate with the next neuron, and that neuron with the next neuron. So you send the signal, right? You have a thought. You have a glass of water on your table. You look at it and you say, I want a drink. So you have to reach out and grab that cup and bring it to your lips and drink it, right? Well, in order to do that, the thought required action potentials. the motor pattern to reach out, grab it, and not miss it. You never miss your cup, right? You grab it accurately every time. Bringing it back accurately to your lips requires proper neuron firing action potentials, all kinds of nervous system coordination. So for a healthy neuron, a healthy neuronal state, a neuron that isn't being used is at a resting membrane potential of -70 millivolts. In order for an action potential to be triggered and for the thought or the movement or the word to be spoken, whatever you're trying to do, that resting membrane potential needs to increase to -40 millivolts and cross this threshold. Once it crosses that threshold, bang, you have an action potential. It talks to the next neuron, and now you're propagating a signal to perform the thought or action that you wanted to perform. Now, in order for that to happen, you must be able to produce ATP. ATP, or adenosine triphosphate, is the energy currency that our body uses to do anything. Whether it's a neuron creating an action potential, whether we're trying to heal from an autoimmune disease, whether we're trying to get swole at the gym, okay? We need ATP to do any of that. And in order to produce ATP, we must have healthy mitochondria. In the brain, we have to have healthy mitochondria in our neurons, but mitochondria are the powerhouses of every cell in our body. So this graphic's looking specifically at neuron mitochondria, but this applies to any mitochondria, okay? Because in order to make our energy, the mitochondria, the powerhouse of our cell, requires oxygen, requires glucose, requires stimulation, and requires balanced oxidative reduction reactions, so balanced antioxidants and oxidation. So optimal brain mitochondria require these things. So when I speak to my patients, I say the brain needs 3 fuels: oxygen, glucose, and stimulation. And stimulation would be exercise or learning, playing an instrument, novel exposures, right? Something that makes the brain say, hey, that's new, I'll pay attention to that. And so if we're sedentary, that could lead to unhealthy mitochondria and poor ATP production. If we have poor blood sugar regulation, that could. If we have poor oxygenation, that could. So instead of having a healthy resting membrane potential at -70, a brain that has unhealthy mitochondria due to poor oxygen, maybe from anemia, say, or from poor circulation, or poor glucose due to poor blood sugar regulation, or again, being sedentary, or if you're inflamed, have autoimmune disease or high environmental toxic load, heavy metals, glyphosate, those sorts of things. Now the ATP production is poor and the neuron function is poor. So the healthy neuron has a -70 millivolt resting potential. An unhealthy neuron has a higher resting membrane potential, somewhere between -70 and the 40, right? So as you can see, if you're unhealthy, it takes less input to trigger the action potential, right? And this can lead to neurons firing improperly, too often, out of turn, or maybe even neuron death due to excitotoxicity from, say, homocysteine being too high, or neuroinflammation from trauma, or from gut infection via gut-brain axis loops, okay? So whatever your weak link is, if it's Parkinson's, maybe you blow up more dopaminergic neurons and the disease progresses further. If it's Alzheimer's, perhaps you're killing more hippocampal neurons and your memory goes away faster. If it's PANDAS, perhaps you're attacking more dopamine receptors and the OCD gets worse, or the tics get worse, or the separation anxiety gets worse. If it's a concussion, perhaps the neuroinflammation is damaging more and more neurons in the brain, so you're having more and more symptoms and recovering more slowly, or perhaps you're damaging vagal nerve, and that's driving the leaky gut post-concussion. So rather than just give a patient levodopa, we need to assess them globally if they have Parkinson's disease. And I've done this with many patients in my office. Chapter 1 in my book is an example of one patient, but you oftentimes have to look at these factors and many others. We can't put them all on one graphic, but these would be the fundamentals, right? Brain needs oxygen, glucose, and stimulation. So we can't have the elderly person be sedentary. If you have Parkinson's, what do they say? Get to rock box, go boxing, strengthen your legs, get moving, right? If you have insulin resistance or diabetes or you're hangry, any sort of blood sugar dysfunction, we need to optimize the blood sugar. Some experts term Alzheimer's disease type 3 diabetes, okay? So it's insulin resistance of the brain. So blood sugar is huge. Oxygen, if you're not oxygenating, you're in trouble, right? You could feel lightheaded or nauseous or dizzy. Well, the brain is an extremity and it's higher up in gravity than the arms or legs. So if you're having poor circulation in the feet, say your toes look, all red, your feet kind of look like Shrek's feet, or say you have what you think is fungal overgrowth in your feet, but no antifungals kill it, that may not be fungal overgrowth, that may be poor circulation, okay? If you have anemia, whatever reason we're not delivering oxygen to the brain doesn't allow us to produce ATP, increases potential for abnormal neuron firing and progression of disease. Concussion, even if you can follow the pen with your eyes, that doesn't mean you can go back and play the game. You need to be assessed for these things, because if we leave these underlying metabolic issues, you're not going to rehab the way you need to. And that's the point I want to make is you could go to Neurologic Rehab and they could create the perfect rehabilitation plan for you and it totally smokes you. So day one, you go and you do the rehab just like they wanted you to, and you're worse. Why? Well, because rehab puts increased metabolic demand on your neurons. And if you have any issues with any of these areas, you're not going to be able to supply or support that metabolic demand. So you're going to essentially smoke your nervous system. And so the answer is not to necessarily jump into an excellent neuro rehab program when you first are diagnosed. You may need to do metabolic work first so that you can create a foundation from which to then rehab. So you want to have optimal glucose, oxygen, and stimulation and other factors so that you can then go into the neurologic rehab and rehabilitate properly, not make yourself work worse, but actually get better because you have the metabolic foundation to do that. So hopefully I didn't, confuse you too much with this. I think the graphic helps it be quite understandable, but the take home is metabolics matter. We can't be super specialized and look only at brain and forget all the things that allow brain to function. So we need to zoom out and say, okay, this person has a head injury or a neuroautoimmune disease. How's their blood sugar? How's their oxygen and iron levels? How's their circulation? How active are they? What's their mitochondrial health like? And all of those things are impacted by their lifestyle, their nutrition, their physical activity, their sleep levels. Okay, so always remember that everything matters. And if you're not getting better or a treatment makes you worse, that's a clue. If a treatment makes you better, that's a clue. We need to pay attention to these clues. So thank you for being on today's call, and let's open it up to questions.
So my nephew had a concussion when he was little, and he's now like 6. And when girls, quiet. When he went back to school, he started having more symptoms like headaches and stuff. But he had headaches like off and on all along. Anyway, they took him to the neurologist, but I was curious if like wearing a mask at school, or even just being at school and having to think harder, I guess that could trigger more symptoms, right? If they're not addressing the whole picture.
Absolutely. Yep. So, just thinking harder. Thinking is neuro rehab in that standpoint, okay? Because thinking is demand on the neurons. And so anything we're doing is taxing the nervous system, because we can't move, think, speak, do anything without the nervous system functioning, right? So if something as simple as going to school and, not even going to school, something as simple as reading a book is smoking him, then he's definitely not ready to go, do something more intense. And so we need to zoom out and say, well, what's going on metabolically, and where can we rehab him? Find the metabolic issue and then rehab those, and then work the rehab in terms of reading or math or some physical movement. Does that make sense?
Yeah. So, I mean, obviously he should go to you, but that's not probably going to happen. I mean, at this point, like, who could help them do that?
Yeah. So you want
to functional doctor?
You want to look for, functional medicine, functional neurology, ideally someone who's got training in both, because again, if you go see a functional, I've had patients that saw functional neurologists, and again, chapter 5 in my book documents this, but a patient who had concussions in football in high school for 12 years, he suffered, he finally found a functional neurology clinic, and they created an amazing plan for him on paper, but the first day he got totally smoked and got way worse. And it's because he was also insulin resistant, reactive to like 50 plus foods, like had all these metabolic issues that wouldn't allow him to rehab the way he wanted to until you got those taken care of. So if you find a functional neurologist who's also trained in functional medicine, hopefully they understand, well, let's start with the metabolics first and then slowly work the rehab in. Make sense?
So those things can go together, but
yeah. So, areas to look for you or for anyone else who's not live on the call, or even if they are, iafnr.org, iafnr.org it's a group that I'm part of that has a locator on their website that looks for clinicians that are certified in functional neurology rehab. And so you could punch in the zip code and see who's close. And it's a cross profession group of individuals. So there's chiropractors, naturopaths, medical doctors, osteopaths, there's some optometrists, there's dentists, like anyone interested in neurology that's a doctor can go and get this training.
Thank you. That's helpful.
Yep.
What kind of success have you had with Parkinson's patients who have gone through the program? What kind of outcomes do they have?
They have great outcomes, and that's obviously not a guarantee, but if we can find the underlying causes and I can create a plan that addresses them and then the person can implement it, then the outcomes are great. And so, like I said, chapter 1 of my book is one example. I have multiple others in my practice who have Parkinson's disease. We find the underlying issues for each individual, they address it, and they improve dramatically. So say, it's not uncommon for patients with Parkinson's to also have restless leg syndrome. So the restless leg goes away. They're not pacing the floor till 2 a.m. anymore sleeping. They can actually sleep through the night, which is huge in helping decrease the inflammation for them and help them recover, right? So that feeds forward into the vicious cycle of healing instead of the vicious cycle of degenerating. So it's all about finding at the individual level what's going on with this person, because 10 Parkinson's patients in my hallway don't all have the same puzzle, right? But in the neurologist's office, they're all treated the exact same. They're, hey, you all 10 have Parkinson's. I'm going to throw 10 scripts for levodopa out in the hallway. Everyone grab one and go, basically, right? So with the levodopa, it may help them, especially short term at least. But if you're leaving the underlying causes that make up the rest of the puzzle unaddressed, they're going to need a higher dose over time as they go, and they're going to degenerate faster because, again, we're not compressing that morbidity, right? We're not addressing the whole picture.
Do you ever get them off of the dopa stuff?
I like the dopa. I like that. I can't legally put a person on or off a medication because I'm a
Right.
chiropractor by license. So
Right.
that's a conversation that we have with their prescribing provider. And that's why labs are key, because labs are an objective piece of paper I can hold up and say, Mr. Neurologist, here was their homocysteine initially. Here was their iron levels initially. Here was their insulin levels initially, or whatever. Here they are now. Plus the patient is reporting X, my anxiety 0 to 100% better. My movement, I have less pain and I move faster, et cetera, et cetera. So, maybe it's time to have the conversation of decreasing dose. Or oftentimes patients will have symptoms creep in that tell them they're overdosed, right? So a common example is hypertension meds. As you get healthier and your blood pressure improves, you'll start to feel lightheaded and dizzy because you're overdosed, right? The medication is lowering your blood pressure too much at that point. So then you say, okay, go tell your prescriber, show them what you've been doing, and it makes sense to come off at that point. But sometimes people can't too. So matter has limitations, So if someone's had Parkinson's for, 15 years and then they come in, the likelihood that they'll ever come off the medication is lower than if someone was diagnosed last year, So that's the whole matter has limitations aspect of it. Is the goal is optimal, and we get to find out together, does that mean no medications, or does that mean lowest possible dose, or what does that mean?
Okay. Thank
I have
you.
a comment.
I knew you would.
Okay, so I have many, but what I want to focus on is the organelle of the mitochondria.
Mhm.
There's a lot of chatter now and a lot of science out there about that little powerhouse organelle. And as soon as we, where the attention goes, the energy goes.
Yep.
Rather, where the energy goes, the attention flows. So we've been talking about, there's various supplements now to fortify the mitochondria and help them function at their peak efficiency. I don't understand all the science behind it, but there is a lot of science out there. And as soon as something comes out that seems to quote unquote work, everybody wants it. So I guess the question is, who needs it and how much of it? We know the mitochondria and the focus is on there as it should be for those who are unwell and those who want to stay well. But, do we, besides foods and healthy lifestyle, do we need those supplements?
What do the tests show us? So I think you could make the argument that everyone needs the certain baseline supplements, say a key multivitamin mineral, a fish oil, a vitamin D. Why? Because our soils are depleted of nutrients. Our seas are toxic. So even if you eat enough wild caught fish to get omega-3s, you're going to be toxic in something else. Even unless you're naked at the equator 24/7, your vitamin D is probably not going to be what it needs to be. So those are, say, fundamental baseline supplements that we could argue everyone needs on some level. But then when you get to, say, supplements like the mitochondrial supplements, that would be more on a patient specific basis. And my opinion would be it should be driven by testing so that we could see, is there evidence, and history and medical exam and all that, but is there evidence in the case that this person is having mitochondrial symptoms, or that the person has comorbid conditions that would contribute to mitochondrial dysfunction? What would an example of that be? Iron deficiency or iron deficiency anemia, right? Because iron's needed to carry oxygen. Oxygen needs to be taken to the mitochondria to enter electron transport chain and spin off the ATP. Are they B vitamin deficient, right? All of our Bs are key to that process. Copper's key to that process. CoQ10's key to that process. So again, that's what you'll see in the mitochondria supplements. You'll see those various ingredients because that's what they're looking to support. So, do you need that whole cocktail, or do you just need iron? That would be a patient to patient kind of determination.
Yeah, in the perfect world, but then you look at most of the people who are out there buying supplements because of advertisement, because they read the science, et cetera, the Niagen, what is it, the mitochondrial Q or some, there's a couple of biggies out there. They're all over Facebook, it's all over social media. You can, look it up and see the peer-reviewed studies, not hundreds of them, but they're out there. And it just, I don't even know what the question is right now. I think that seems to be where people are looking, and it looks like a really smart area because you support the mitochondria man, and you really do support all the things that it supports.
Yeah, I mean, you could argue that you could take it, and if you don't need it, you're just spending money on something you don't need. Is it going to hurt you?
Wouldn't harm you.
No, it's not going to harm you. And like you said, the research is coming out that we're learning more and more about the mitochondria and about these nutrients every day. And what happens is that many of these nutrients support the mitochondria, so that promotes optimal health and anti-aging, so to speak. But when we dig down to the DNA level, a lot of these nutrients are shown to be what are called senolytics. So seno from senile, right? So as you age, you become senile, so to speak. Well, a senolytic is something that slows aging or is anti-aging. Well, how do we age? In our DNA, we have things called telomeres. And telomeres you could picture as the end cap on your shoelace, right? That piece of tape that's that nice end cap. Well, every time a cell divides, that telomere is shortening throughout our life until it's so short that we can't divide anymore and we die, right? So if we can slow telomere shortening, we can slow aging. And so senolytic products are shown to slow telomere shortening. And so they are anti-aging. And many of those support mitochondria, and the mitochondria has its own DNA. So that would be a mechanism by which they work. And my experience, both personally and with people I've worked with, is the mitochondrial supplements don't necessarily ever give you that wow factor that you might get from a vitamin D or a fish oil, or one that you really needed that you didn't have. So it's kind of like you take it for a few months and you're like, well, I don't really feel different. Do I want to spend this money on it? Because they tend to be the higher price supplements, the mitochondrial ones. But at the same time, you don't feel yourself aging either, right? So it's one of those things that.
Well, but you don't, but I do. I've got a few years on you.
Right. But but on the scale of 3 months, you might not notice it, so you dump the supplement. Whereas if you have a supplement that really helps you with pain and you drop it, you notice that right away, right? So I think supporting the mitochondria, you're not going to go wrong if you're doing it. It's a little bit harder to feel that it's working unless you have a mitochondrial disorder, or you're farther down the illness path. But you're not going to hurt yourself other than maybe spending money you don't need to.
Well, I just have to throw this in for whoever listens to it, both now or later, that I thought it was pretty cool. And after our limited conversation, I thought, well, I'm going to give it a try. I'll tell you, I think it's pretty amazing. In only a couple days, I felt like somebody turned up the volume on everything. Yeah. And my tiredness during the day kind of disappeared. I jumped out of bed in the morning, jumped out of bed. Now, it could be psychosomatic, but I don't think so. Because I forgot that I was even taking it. It was like, boy, do I feel good. It's like, oh, just maybe it's that supplement. Yeah.
So a little more time will help you understand, is it that or not, right? And then if you really want to empirically test it, you could drop the supplement off, for a couple of weeks. How do I feel? Am I still jumping out of bed?
Of course.
Right. So, so let us know.
I will.
Stop it and then keep us posted.
I will, but I mean, I know there's a few of us, not everybody, but a few of us here who are in the older age group, despite the fact that I fight it every step of the way, and feeling more youthful and more energetic ain't a bad thing.
No, I would call it
agree. I'm in your group.
Yes.
I would classify it the wiser age group.
Right.
Yeah, I'll take
We have wisdom.
Yes.
Correct.
Yes.
I'm entering it. My wife tells me about my grays all the time. So I just say, I'm getting wiser. I'm not mad at it. So what else?
Okay.
Who else has comment or question?
I have
This is the
something.
kind of stuff you have to really digest. I'm sorry. Go ahead.
Go ahead,
Um,
Janelle.
Another family member that I want to ask about that I've been meaning to. So she's 68, I think, and it relates because she went to a neurologist, but she feels like she's kind of tingling all the time, like throughout her body. Like it never really stops, like 24/7. She's got kind of this tingling feeling going on all the time. And the neurologist said that she doesn't have MS. So she was really thankful for that because her sister did. And her mom died of Alzheimer's and her sister has Alzheimer's. But I mean, does anything come to mind?
Yeah, so tingling would be a paresthesia, which could be a neurologic symptom. So it might not be a central issue. So if it's nerve, say, it might not be a central issue. It might be a peripheral nerve issue. But if it's all over the body, it's probably more central because, right, if it's just a peripheral nerve issue in the right arm, well, then why would the rest of her body be tingly, right? Mm-hmm. So maybe more of a central issue. It might not be neurologic. So again, if we go back to right here, the metabolic stuff, right? B vitamins are key for nerve function. B12 is needed to make the myelin sheath that coats the nerve so that the signal can conduct. So if, say she were B12 deficient, she might have numbness and tingling or just tingling all the time. Or vitamin B6 is key for nerve function as well. You know, there's lots of nutrients that are key for nerve function. So if the neurologist says your MRI is clear, you don't have MS, or we did a CSF puncture, you don't have MS, or they ran antibodies, you don't have MS. Well, that just rules out one disease. That doesn't mean it's not neurological. But if they did all kinds of other things, you know, the neuro exam is clear other than the tingling, well, then maybe it's not neuro, maybe it's metabolic, maybe it's a B deficiency, maybe their hemoglobin A1C is 8 and they have diabetes, you know. There's other things it could be. So it wouldn't be stop looking. It's just, okay, now we have to maybe zoom out from the neurologist's office and say what else could be going on.
She's never slept well, like in decades. Could that be, I mean, I know everything's related, but could that directly feed into it?
Yeah. Directly, indirectly, right? So if you don't sleep well, that increases your inflammatory or your susceptible, it increases your inflammation, and inflammation is the lowest common denominator to anything, right? So for her, maybe it's tingling. For me, maybe it's heart disease. For you, maybe it's cancer, you know, sorry to give you cancer, but you know what I'm saying? Sleep deprivation, we all give it lip service, like, hey, yeah, I know I need to get more sleep, but then we don't do it. But I mean, sleep, our whole physiology is based on circadian rhythms and ultradian rhythms, and sleep is key to that. So if we're really not sleeping and we're not sleeping well for decades, you're setting yourself up for whatever your time bomb is. So that's, you know, that's going to be key. And it's more indirect, right? Because missing sleep isn't necessarily going to manifest neurologic symptoms tomorrow, right? But missing sleep compounded over time drives up the inflammation, and inflammation triggers our weak link, whatever that is. And another piece about the telomeres with Linda and aging, you know, if you're not sleeping, that's when we recover, right? So if you're not sleeping, you're going to age faster, especially if it's, you know, chronic insomnia or sleep deprivation. Anything else? So let's get our sleep, and then make sure, you know, make sure our metabolic state is well. Real quick, I had a consultation with a lady yesterday that's had 4 concussions in the last year or two, and she started to develop GI issues. And she said, you know, do you think it's from my concussions? And I told her, I think the concussions are probably contributing. And she said, well, I didn't have GI issues after my first concussion. Well, again, matter has limitations, right? We might be more resilient the first time we bonk our heads than the fourth time, right? Her fourth time she concussed, her dog headbutted her, basically. Like, that shouldn't concuss you if you're playing with your dog, and unless they hit you just right. But so there's two things there. The more we hit our head, the more susceptible we are to issues, right? But then the healthier we are leading into a trauma, whether it's a head injury or whether it's you know, getting an X-ray or whatever, the healthier you are from an inflammatory standpoint, the less inflamed you are, the more resilient you are. The more inflamed you are going into it, the higher the risk of bad outcome or worse outcome, right? So that's one thing. So she was probably in a healthier state at the first head injury, plus she hadn't had 3 other head injuries, right? But you have you then have 3 head injuries. The fourth one probably is going to lead to bigger issues, because it's like, here we go again, here we go again, here we go again. Okay, so that's the importance of metabolic health, not falling off, you know, the lifestyle, making sure we rehab properly and thoroughly. You know, which for kids, it means we don't want to rush back just because we don't want to miss 2 games. It's like, well, if you rush back and reconcuss, you might miss a season, you know. So we have to consider what's best for the long-term health of the individual versus, you know, wins and losses sometimes. And you see that in the NFL every week. So unfortunately, they are just meat. Their long-term health isn't a consideration at all. It's, you got to play. So what else? Anything else? Awesome. Well, thank you for being here, and have a great week.